So welcome, Dr. Devulapalli. Thank you for joining us as our next guest on the Doctor Marketing Agency podcast. We're excited to talk about some of the issues that are plaguing and affecting a lot of Americans when it comes to spinal compression fractures. I think that May is Osteoporosis Awareness Month, and it's important to kind of shed the light on this sort of condition that's impacting so many out there. And thank you once again. It's a pleasure to have you as a next guest on our podcast. Before we continue, Dr. Devulapalli, I just wanted to kind of turn it over to you to provide a bit of an intro and a bit of a background on yourself and your career as well as your practice. So I'll turn it over to you.
Great. Thanks so much, man. I really appreciate the opportunity to do this with you. My name's Devulapalli. I'm an interventional radiologist. I've been practicing after training now. Originally from Ohio, did most of my training medical school there, then trained out in California for residency at UCSF and then fellowship at University of North Carolina. After leaving fellowship in 2018, I was in practice for a couple of years in a pretty traditional hospital-based radiology practice. I left there to enter the outpatient world, and I've been mostly outpatient ever since. So originally in an outpatient lab with a cardiologist, and then did some contracting, and our family, we settled in Missouri, and that's where I am right now, Columbia, Missouri. Moved here several years ago and opened an outpatient practice. Our practice is Image Guided Solutions of Missouri. I'm a solo outpatient interventional radiologist in a rural community centered between two larger metro areas in the middle of the state. And we deal with several conditions, but certainly vertebral compression fractures are a big part of our practice, a pretty significant part of it, in addition to vein work and embolizations. So we have a lot of fun doing that and helping the folks locally and in our region, and it's been great. So excited to join you here today and talk a little bit more about it.
Well, fantastic. Well, thank you for that synopsis and that kind of background, Dr. Devulapalli, in terms of your career. You've mentioned spinal compression fractures, which is what we are talking about today. Just for the sake of, elaborating and get more clarity for our viewers and our listeners, can you explain what is a spinal compression fracture?
Sure. So a lot of our listeners, may not be aware, but they probably have maybe some basic knowledge. Our vertebral bodies and our spine, they're kind of like building blocks. And what they do is they support our weight and our posture, and they're very critical. Compression fractures basically refer to the phenomenon where a vertebral body that looks like a rectangular block could end up becoming kind of wedged, and what can happen is it can collapse, and that's basically a compression fracture. They're often due to a couple different reasons. You can get them after a bad accident, for instance, car accident, something to that effect, some major trauma. They could also happen silently. And that's a big component of what we'll probably talk about here today. But it does refer to the phenomenon where the bone breaks, and what will happen is that bone will go from looking like a rectangular block to more like a wedge, and it could really flatten and almost look pretty flat, almost a pancake look. So it could be pretty severe.
Okay. So, at the end of the day, a lot of potential patients are going through this, but I think, highlighting, you mentioned the fact that the fracture is so significant, it could be silent. That kind of takes me to the issue with regards to the bone deformity and the actual impact around that area. Dr. Devulapalli, osteoporosis is something that there's a lot of research and a lot of education out there if people go ahead and, follow that understanding and put in the due diligence to get more information about that. Can you just explain, kind of in layman terms, what osteoporosis is all about?
Absolutely. So the easiest way that I tell patients every day is imagine you have a house and it's made of wooden beams. And these beams are really nice, they're sturdy and they support the weight of the structure. Now imagine a bunch of termites bit into those wooden beams and created a bunch of holes in them. That's in essence what osteoporosis is like. We're taking a very rigid structure that's bone, full of calcium and minerals, and we're turning it into a structure that now has a lot of holes. It's very porous. It's softer. it doesn't have the same consistency that it should have. And therefore, it's very likely it's at high risk to break. And that's osteoporosis in a nutshell.
Okay. So, that's a very, very nice analogy and explanation. And I think, the way you've kind of mentioned it right now, Dr. Devulapalli, comparing it with the wooden beams in a house and then the impact that the termites are having, I think that paints a great picture for somebody that's new to this, trying to get more information, trying to determine if they are a, person that's potentially being impacted or affected by this disease and this condition. Um, so we spoke about a bit on the spinal compression fractures and osteoporosis. Dr. Devulapalli, with your expertise and your knowledge, who would you say are patients that are most at risk of spinal compression fractures and having the need for treatment?
It's a great question. So, one of the things that we realize is there's a lot of patients out there, number one, and especially older patients. So, especially women. Women are at higher risk than men, though it is still very common in men, and especially postmenopausal women, so older women, because what happens is after menopause, the hormonal effects no longer or can put a patient at risk. You don't have the same bone density that you had premenopausal.
Mm.
So older women, certainly, we're talking about women generally in their 60s and 70s. They're very high risk. And then men as well, as they age, could also be at risk of this as well. It's not as common in men, but overall, since it's so common in the general population, we do see a fair number of men with it. So age, that's certainly one of the biggest risk factors. Another
Right.
risk factor that we see are patients who are on steroid medicines. So oftentimes we see patients who may be treated for other conditions, like other inflammatory or rheumatologic conditions, rheumatoid arthritis, for instance.
Right.
Patients who've been on chronic steroids are at high risk of this. Even patients who have asthma or COPD, have lung issues and are put on steroids to help with that. We see a fair number of those patients as well who are at high risk of having osteoporotic fractures. There's other risk factors as well, certainly lots of alcohol consumption, smoking. These are all risk factors. But I'd say the biggest one that drives what we see here in our practice, but also nationally, is age. So definitely a condition that affects older patients.
Okay. So that's interesting. You mentioned women and May happens to be Women's Health Awareness Month. And it's just interesting that, with so many impact factors that, interventional radiologists, such as yourself, are treating women for, this is just one of those that they need to, be able to do their proper analysis, determine if there is a need to do a checkup and be able to, research this to realize that they could be at risk because it's always important. I always, realize this that they are able to detect these at an earlier stage rather than it becomes more later and, more detrimental towards their health. Um, so, Dr. Devulapalli, how often are osteoporosis related fractures overlooked or misdiagnosed? Because you hit on something kind of important here that it's not just simple back pain that we're talking about, which a lot of people might assume. But is this something that you come across in your, practice and when you are dealing with patients on a day-to-day basis?
Absolutely. So, you hit the nail on the head. This is often overlooked. It's often underdiagnosed. It's often undertreated. And I think there's a couple of reasons for that, but one of the biggest reasons is that back pain is so common. Most people at some point in their life, especially once they even get into their late 30s, 40s, and beyond, will have instances of low back pain. And, oftentimes that's not related to a fracture. It's, oftentimes muscular. It could be related to posture, it could be related to overexertion of back muscles, hamstrings being too tight, a variety of reasons that aren't necessarily related to the bones. Then as we get older, the bones in our spine, they can start to degenerate, just like bones elsewhere in our bodies, like the bones around our knee joints, for instance, or our shoulder joints. And you get arthritis and you get changes related to that. That can cause back pain. And, these two areas that we're talking about, muscular strain and degenerative changes, are probably the number one and number two reasons for back pain in the country. And then you have issues related to the bone. And it's very easy to overlook because when you're talking about the entire gamut of back pain, you're not as likely to have a broken bone be that reason. But it is overlooked, and especially in the older population, it's overlooked. There are 700,000 newly diagnosed compression fractures in the United States every year, millions globally. And I would say that about one third of those fractures cause significant pain, and two-thirds are actually silent. So they could happen and they may not be picked up unless a patient had an X-ray or a CT scan or an MRI for some other reason. So it goes to show that there's a lot of patients who have back fractures. Not all of them are what we call clinically significant, a fancy way of saying doesn't necessarily cause pain,
Right.
but a good proportion do, and they are often overlooked.
Okay. And so, you mentioned something extremely important. It's such a broad area, broad topic of back pain. We think about the different forms of back pain that a lot of people are researching and realizing that they need to go and see either a PCP or they're going to go and see an orthopedic surgeon because they assume, okay, I might have sciatica or I might have scoliosis or I might have one of the other forms of back pain. But, when you mention 700,000, that's a large number of people that are getting diagnosed with this. And the fact that they are not aware of it, it's excellent to know that there's practices such as yours that are, providing this consultations and allowing them to come in to see a specialist such as yourself to determine, because you mentioned the imaging and going for these type of scans. That's when they might only realize that this is a actual fracture that's been plaguing them or impacting them for years, and now it comes to a stage where something needs to be obviously done about it. So that's very interesting to note. We talk about vertebral augmentation, Dr. Devulapalli, and if you look at some of the minimally invasive options that are out there, some of those that have come to mind are vertebroplasty and kyphoplasty. For the sake and understanding for our listeners, can you kind of, provide a bit of a better explanation between the two?
Sure, absolutely. So, there's a lot of fractures as we talked about. 700,000 is a large number, and about a third of them will have significant pain. And hopefully, we do a good job as a community to identify those patients as much as we can.
Hmm.
And oftentimes, what we will do is patients have significant pain related to their fracture. We will offer them minimally invasive treatments. And there's two that you mentioned that we absolutely offer. There's vertebroplasty and kyphoplasty. Now, they're very similar, but there are some differences.
Right.
So the larger bucket term that we use is called vertebral augmentation, and that's a fancy way of saying that we're actually doing something to the vertebral body to try to restore it or try to make it more rigid, basically fixing the fracture, if you will.
Right.
Vertebroplasty is the traditional way of fixing a vertebral body, and this is where interventional radiologists will put one or potentially two little needles into the vertebral body, and they'll simply inject what we call medical grade cement, PMMA, polymethyl methacrylate, just call it cement. And this is basically medical grade sterile cement that'll go inside the bone. It'll seep through the pores and the areas of breaks in the bone, and it'll solidify. And providing that solid structure can really make a big difference for a patient. We can see patients going from 10 out of 10 back pain to very little to no pain almost immediately after the procedure. So it's a very nice procedure, works very well. That's a traditional way of doing things, vertebroplasty. That has to be distinguished from, I guess, a more modern technique and one that more and more people are adopting and have adopted, and that's kyphoplasty. Kyphoplasty refers to the process of creating a cavity within the bone. And the thought process is that if we create a cavity, we can try to, one, regain structure. So if you have a vertebral body that's like a nice solid rectangle and it becomes compressed, more like a triangle shape, we can actually try to restore the height. And that's what kyphoplasty tries to achieve. Traditionally, this is done with a balloon. So it's a little balloon that goes into the vertebral body through the needle. We can inflate the balloon. And after we inflate the balloon, what happens is the areas of broken bone will be more or less, displaced to the side of the vertebral body. And we fill that little cavity with PMMA. And the thought process is by doing so, we can increase the height, we can help restore alignment of the spine, and we can also help contain the cement, decrease the likelihood of it potentially seeping outside the bone. I want to make it very clear to listeners overall that this is a very safe procedure. even traditional vertebroplasty is still a very safe procedure. Kyphoplasty is more of a modern adaptation. And then there's a actual third category of these procedures. It's called mechanical augmentation. And that's a process where we can actually put an implantable device into the bone to actually increase the height of it. And there are several of those devices out on the market, but a common one that folks use is in my community is a device that's akin to a car jack, if you will, called
Okay.
spine jack. But the thought process is with mechanical devices, you can increase the height, you can create that rigidity, and create that structure, help regain alignment. So this is kind of the progression of vertebral augmentation over the years. They're all very safe, they're all very effective. And there are certain instances where we, as interventional radiologists, as operators, may choose to deploy one technique versus the other.
Well, I think you brought up a great point there, Dr. Devulapalli. We look at each patient's case as being unique. And, if someone such as them were to come through to your practice, you'll be able to determine whether they are a candidate for vertebroplasty, kyphoplasty, or mechanical augmentation, as you mentioned. Some of the newer techniques that have been introduced, because it's very interesting when you kind of hear about how potentially cement could be injected to kind of increase the height or being able to use a device. I think with the modern advances of technology that is out there at the end of the day, this is still something very reassuring because uh, I think what makes this more relevant is the fact that you are giving them more than one choice. And, it's something that's been proven with research, with documentation, with papers that have obviously been placed that this is the type of studies or clinical studies that have been done, trials that have been done, have now led to these type of successes. Dr. Devulapalli, on that point, you talked about, reassuring patients how safe it is. And I think that's probably of paramount importance to them when they come over to a practice such as yours. Because at the end of the day, I think what's important is they've got to realize, um, okay, we've got this potential situation that's impacting us, but we want something that is minimally invasive. And the word invasive cannot be emphasized enough. What makes, some of these alternatives that we have in the marketplace, like kyphoplasty, much more attractive in an outpatient setting compared to invasive spinal surgeries?
Yeah, I think it's a great question, Vin. There's a few things. I think one, we're able to have patients come and go the same day, and that is the most important thing. This is a very fast recovery. When we're talking about spinal surgeries like fusions in a hospital, for instance, we're talking about major back surgery. We're talking about having a breathing tube put in, general anesthesia. There's risk with that. There's more time. There's generally, nights in the hospital recovering from a major surgery like that. There's going to be pretty significant, rehabilitation, other measures afterwards. We're talking about significant time off from either work or other activities. And that has to be contrasted with the minimally invasive approaches that we can do. Everything is outpatient. Patients come and go the same day. Procedures generally take less than 1 hour. The recovery afterwards is generally pretty quick, 30 to 45 minutes. In terms of downtime, it's very, very minimal. Our restrictions overall are very low, just no heavy lifting or strenuous activity for a week or two. And I think it's just the ability to know that we can do this very safely and quickly. We can get patients booked faster than oftentimes they can be taken care of in a hospital setting. So it's really nice because if we're able to shift care from an inpatient setting where we have a lot of sick patients who need the attention of dedicated physicians in that type of facility, we can take care of a subset of these patients here in the outpatient center, in a center that's convenient, that you can park and walk right in the front door, visit your care team, get treated, walk right out. Pretty hard to beat that. So there's definitely some key advantages, both from a convenience standpoint. And then the other thing that I'd like to mention is it's very safe. There's a very, very low minuscule risk of infection. I'd contend that on the outpatient side of things, it's probably even safer than hospital settings where you have a lot of sick patients. So I think there's many factors, but several, particularly related to patient convenience, that make this appropriate.
So there's a lot that we can take into digest from what you just mentioned, Dr. Devulapalli. But I think that it's becoming more and more popular. You mentioned the outpatient environment, the office-based lab, coming in, being able to perform and get your treatment, and being able to go back the same day. The risk of any infection spreading from other patients, etc. These are very very important topics. But coming back to vertebral augmentation, we talked about spinal compression fractures. It's interesting that health does not make a difference irrespective of your background. You could be um, Steve Jobs or Elon Musk, or you could be an everyday person, but you all are impacted and plagued by health issues. And the reason why I actually kind of bring up those two individuals, unfortunately, someone like Steve Jobs was a pioneer in the world in terms of what he created, but he ended up passing away from pancreatic cancer. Somebody like Elon Musk, and why I bring his name up specifically is here's someone that's being regarded as a tech leader and sort of a titan in the corporate world. Yet I read an interesting piece the other day that he was going to be going for a kyphoplasty procedure because he needed to be able to go for something that was minimally invasive and that was impacting him. So I think that at the end of the day, when it comes to somebody's health, it's so important that they are able to reach out and realize that these are the options that they have available. Thankfully, we are living in the 21st century when there's more patient education around where they can kind of get more an understanding of the type of advances in technology that we have and the type of treatments that they can go through. But on that interesting topic that I kind of mentioned, and not to kind of go off on a tangent, but kind of give you that bit of explanation, Dr. Devulapalli, for our viewers and listeners, I think I'd like to turn it back to the focus of attention being yourself. And what I find very interesting is that we talk about your background, coming from Ohio and California, and your training, being in sort of an urbanized in setting, previously with the part of your career. How has that transition been? By now, you kind of moving into this more rural environment. What are some of the unique challenges that you've seen when it comes to patient care that you've had to kind of put your best foot forward with when it comes to treating patients in this type of setting?
Oh, I think it's a great question, and I'm glad you asked it. I'll tell you, I never thought I'd work in a setting like I currently do. Wasn't really sure what to expect. I spent most of my life in larger cities, larger places, either urban or suburban environments. And I will say it's been very positive, but it's certainly not without its challenges. I think when it comes to especially osteoporosis and vertebral compression fractures, I think the hard thing we struggle with, number one, is awareness. And I think it's actually a little bit more magnified in rural environments than maybe urban care centers. I think there's a little less awareness of these issues in communities. I think there's the cultural expectation that folks kind of tough it out, which in many ways I really love my patients, and I
Right,
love I love their resilience. We
right,
have a lot of really honest, hardworking patients who do a lot. They run farms, or they're very active in their communities, and they really respect their healthcare providers and physicians, and it makes for a wonderful environment, especially compared to maybe some other places I've been in the past. So I love that part of it. But with that, the awareness could be a challenge. I think also related to that is coordination of care is very, very tricky at times. Being in the center of a large state, it's a college town. We have patients who come from very far distances, upwards of 2 to 3 hours, as far north as close to Iowa, and as far south down to Arkansas, and pretty much everywhere in between. And when it comes to compression fractures, we rely on modern technology, especially as interventional radiologists. We're a very, modern field doing minimally invasive techniques, and we
right.
need advanced imaging to support a lot of what we do. So we have some challenges coordinating things like MRIs, especially patients who live from far distances, trying to find places where we can get it done, getting images transferred. So there's a lot of coordination challenges that come with it, a little bit different from being in a suburban or more urban area where you have a large number of imaging centers, maybe a greater likelihood of streamlining things. I think we do a very nice job of that here in Columbia. We have a good partnership with the Columbia Orthopedic Group. and we work very well together. But even then, there are inherent challenges to having patients come from a far distance. It's an honor to have their trust and be able to do that, but those are things that we work through. I think that makes it a little challenging, and grateful for opportunities like this because it can help increase awareness.
Sure. You're welcome there, Dr. Devulapalli. I think that, I appreciate the context that you kind of mentioned about the core, sort of in terms of patient coordination and when it comes to the different challenges that you experience. But I think that, at the end of the day, I could see the passion coming through, the way you're speaking about what it means to you to be an interventional radiologist. And I think, importantly, how to bring these advanced interventional radiology sort of techniques to the patients, to the masses that you are seeing in your community. I think that at the end of the day, I'm sure this is something that you've got into the business of kind of medicine to be able to practice medicine with the intention of providing the best care to patients. Physicians, providers, doctors, however you want to kind of classify or categorize them. At the end of the day, it's always about putting the patient first. And it's about treating patients rather than cheating patients. And I think that's so important in this day and age, because at the end of the day, someone puts, their health in the hands of a provider, or when they're coming through a clinic where they are obviously seeking the best type of advice. How do you feel, Dr. Devulapalli, important patient education is? Because you mentioned something about, the distances patients are traveling to your practice in and around Columbia. And I'm sure this extends, as you mentioned, to parts of Missouri and Arkansas. Is there any options out there that your practice has been able to look at in terms of advancements whereby you are able potentially to do any telehealth communication or consults, depending on the nature of the condition, whereby you are able to see patients from, as you mentioned, 2 to 3 hours away, and then if they are you determine that they could be a potential candidate for this type of a consultation and procedure. Is there something that we should be aware of that you are potentially have in the works or have been already practicing with your practice when it regards to patient consultations?
Definitely. Telehealth is a huge component of it. There's no question about it. Our preference is to see patients in person if we can, because it's important that we stick to our roots in our physical exam and history
Right.
taking. And there's a lot we glean from just watching a patient walk, actually, from our waiting room to the exam table. That tells me generally most of what I need to know, believe it or not.
Right.
But with that being said, we have patients in debilitating pain who are coming from hours away. So we definitely employ telehealth for I would say a good minority of our patients. We do that. So a decent proportion. Imaging review, video review, certainly. We're also utilizing more text alerts for patients, for those who are able to do that, which has helped in terms of disseminating education, post procedure instructions. So we're trying to modernize some aspects of that care. Still a little challenging. I think so I think a lot of our patients do value the in-person, face-to-face communication. I do think that regardless of whether we're doing telehealth or in person, the educational component is the vast majority of that initial patient encounter. I would say average encounter, probably a total of 45 minutes generally, if not longer. We spend, probably the minority of time actually talking about the procedure itself. We spend a lot of time talking about osteoporosis. And that's very, very critical. As I tell every patient who we interact with, for this procedure, what we do is great. We're able to fix the bones. We're able to make patients feel better. But unless we have a strategy for addressing the underlying condition that a patient has, which is the osteoporosis, um, the patient's still at a very high risk of future fractures. It's a hard thing for a lot of folks to hear. They want to just have one little thing and be done with it. So it takes some time to sit down and discuss that and help educate our patients. And I think they appreciate that. I think after we do that and we set the stage right, we're able to engage in a good, meaningful partnership and help get them along their way back to independence and autonomy.
Now, that's very interesting. So there's a lot of coordination that's involved, Dr. Devulapalli, but I kind of wanted to just potentially elaborate a bit more on those partnerships that you mentioned. You mentioned Columbia in terms of the orthopedic group that you work with, but how do you also collaborate a lot of the times when it comes to other physicians, primary care physicians, potentially, internists, endocrinologists. Do you feel that there's a good system kind of in place? The fact that you are able to, be a referral source, because at the end of the day, we're not just at your practice treating osteoporosis or spinal compression fractures, right? There's other minimally invasive treatment that you are, obviously taking care of with patients that have any underlying conditions like inflammation, or you mentioned arthritis. How do you believe is, the importance of being able to work with those other providers over and above the orthopedic group that you mentioned earlier?
Yeah, it's critical. There's no question about it. I think, one of the great things about being an interventional radiologist is we have such strong imaging expertise. I think we understand disease and we understand the imaging anatomy behind that disease probably better than most types of physicians because that's our training. I think one of the challenges is when you're an independent interventional radiologist, you think you can do everything, but you realize very quickly that it's not the best to take on everything yourself. Your time is limited, and you have to question how many patients can you impact every day. So engaging with other physicians and being a referral source for other physicians and trying to treat patients in a team-based manner is critical. I think certainly just logistically critical, but also in the best interest of patients and making sure that they're hearing about all different options. I'll tell you specific to what we deal with compression fractures is back pain is hard. It's one of the hardest things to deal with. And I think oftentimes as interventional radiologists, we're very laser focused on the condition that we have a minimally invasive treatment for. And that is our training. We're taught that if you have a back fracture, we can fix it with vertebral augmentation. And that is largely correct the vast majority of times. However, I've learned that life is a little bit more complicated than that, and
Right.
our bodies are a little bit more complicated than
Sure.
that. So I think a couple of things. I think one, the osteoporosis part of it is critical. And in many communities, not just here in Colombia, but across the US and across the world, osteoporosis management is something that's probably not done enough of. And it is actually challenging to find dedicated physicians who are focused solely on this, or that is a major part of their practice. We have wonderful endocrinologists in our community. They're oftentimes booked 3, 6, 12 months out. And if we have a patient with a newly diagnosed compression fracture, it's kind of challenging to get them in. We do have a bone health clinic with the orthopedic group that we do interface with very closely. So we've been able to work in a multidisciplinary fashion to help get patients to osteoporosis treatment. We're doing a lot of that education in our office initially, but then we are relying on our partners over at the orthopedic group to help take care of these patients to get their bone densities back up and to get their bones healthy after we do the treatment. So there's a lot of coordination there. That's one aspect of it. The second aspect of this is pain. So obviously, when we're treating patients, we're trying to get them out of pain. And the reason I made the comment that back pain is so complex is because there are multiple regions of our back or parts of our back that can cause pain.
Right.
And when it comes to compression fractures, the term that we use is mechanical pain. This is pain related to the actual structure of the bone. When the bone is broken and a patient tries moving, little pieces of bone rub on each other and it hurts. That's why patients with back fractures will often say, the only time I'm ever comfortable is if I'm laying perfectly still. Well, what ends up happening with a lot of patients is they have multiple areas of their back that will cause pain. So obviously the fracture causes a significant proportion of that pain. And we're able to get rid of that by a kyphoplasty or vertebroplasty or mechanical augmentation procedure. We're able to take care of it. However, what will happen in a good minority of patients is they'll have other reasons for having nagging pain. They might have some degenerative changes in their spine. They might have some posture related issues because of the fact that the bone broke and collapsed and we could only restore so much height. So we do work very closely with pain management physicians in our community. We're very critical in helping care for other issues related to the back that are causing pain that aren't vertebral compression related issues. And I would say, somebody might ask me, isn't that something that you could do as a physician? Yes, I think I could definitely. We're trained in a lot of these things. However, if we were to do that, we wouldn't be able to have the same impact and reach for all the patients with vertebral compression fractures that are out there. So one of the challenges of working in a community that's rural, where there's a lot of patients and not as many physicians, is you have to pick and choose your battles, if you will, very wisely and put your resources that makes the most sense for patients in your community. So because of that, we're able to actually have good multidisciplinary care between folks looking after osteoporosis, between pain management doctors dealing with chronic back pain, and then ourselves here in IR working on vertebral compression fractures. Together, we have a nice multidisciplinary core.
Yeah, it's interesting that you mentioned that, Dr. Devulapalli, because interventional pain management physicians, and there's so many areas of back pain. That's one of the issues that, with May being Musculoskeletal Awareness Month as well, that we've realized and come across that pain is so broad, and quite often when you are at a practice, and I'm sure you've seen this when you've spoken with your staff and your team members, patients are calling through to say that I'm in a lot of pain, and then we're trying to quantify or categorize what is that pain. As sort of physicians that treat vascular issues, we spoke about spinal compression fractures, we spoke about venous issues earlier, embolizations for those, etc. It's interesting because you never quite know. A patient realizes, okay, I want to be pain free, I want to be off the meds, I want to have, I've tried physical therapy, I want to be able to move around and do what I'm doing as best as I possibly can. Not take the sort of smaller things for granted. And these are folks that are even more elderly. You mentioned age earlier, being such an significant and important factor when it comes to spinal compression fractures. So, as you are trying to enjoy your years with your grandkids or with your family, maybe going into retirement, and you've worked so many years, sort of given your labor and sort of put in your fruits of labor, you now realize that there's this time where you want to kind of take it a bit easy, step back, and enjoy life. And here you are experiencing these issues where pain becomes debilitating. It impacts your daily life. And you mentioned it extremely well. It's so important that you are a physician and running your own practice whereby other doctors and providers and physicians can refer patients out to you as a specialist within this entity when it comes to, spinal compression fractures.
Absolutely. And it is very much a team-based approach. I think, could one person do everything on their own? I doubt it. There's only 24
Sure,
hours in a day, and there's a lot of patients. There's a lot of patients, and there's not enough physicians, I feel, especially IR physicians focused on this area.
sure. Okay, fantastic. Well, Dr. Devulapalli, in conclusion, I would like to kind of just end off with, for our listeners and viewers out there, is there anything in particular that they could take as a key takeaway when it comes to spinal compression fractures? We've spoken about the issues that could be the root cause. We've touched on the fact that, these are the symptoms that they need to be conscious and aware of and the treatments thereof. But with your expertise and being a subject matter expert on this, um, is there something that you'd like to leave them with that they should, bear in mind when they are potentially trying to do a bit of research, putting their patient education to determine if they could be, impacted or affected by any of these spinal compression fractures that might need a treatment option like kyphoplasty or vertebroplasty?
Definitely. I think one, especially for our audience over the age of 50, I think low back pain or back pain in general, take it seriously, right? I think there's a tendency to just kind of put it to the side. But I will say if you have pain that is so severe that you can't function, that is not typically a function of just getting old. I will tell you
Yeah,
that. Definitely get it checked out. Talk to your primary care physician about osteoporosis and about getting screened because there is screening for that. And in the form of an X-ray, it's a DEXA, DEXA scan.
okay.
And that is very, very critical, especially for men and women over the ages of, 65 in particular. It's going to be very critical. So I would look out for those two things. Definitely take osteoporosis seriously. Know that especially as women age, women in particular, they will statistically have osteoporosis. So I would just take it very seriously, get that checked out, and make sure that we're staying on top of it.
Well, fantastic. Well, thank you so much, Dr. Devulapalli. It was a pleasure having you, as a guest featured on our podcast. I really appreciate the insight, and I'm sure I can talk on behalf of the audience that it was very educational. You provided some great background as to, the issues that could be impacting them when it comes to osteoporosis and, spinal compression fractures, but also providing your understanding and expertise about how you are able to navigate seeing patients in the traditional environment that you have, with focused on the more rural aspect of pertaining towards their healthcare. So it was a pleasure having you on board, and I'm sure that if there are any issues that patients within your region are obviously experiencing, they know who to call now with Image Guided Solutions of Missouri.
Excellent. Thank you so much, Vin. Appreciate the opportunity. It's a pleasure chatting.
You're welcome, Dr. Devulapalli. Take care. Keep
Thanks,
well.
you too.
Okay, bye bye.
Bye-bye.